Hi, everyone, and welcome to another one of our SCAN virtual lunch and learns. I'm Andrea Tarr. I'm the program director here at SCAN. We have two excellent presentations for you today. Before we get into that, let me just give you a little bit of info. We are recording today's webinar, and after it's recorded, there will be a link that gets sent out to everyone for our YouTube channel. It'll be in a kind of a thank you message. And you'll notice that on the bottom of your screen, there is a chat function. So we encourage you, if you have any questions, just type them right in the chat box, because Mary Beth is going, and I will be monitoring that. And as time permits, we will ask as many questions as we possibly can. Okay, Mary Beth?
Hi, everyone. I'm Mary Beth Kwapniewski. I'm the program coordinator here at SCAN. Again, it's September, so it's Women's Health Month, it's Fall Prevention Month, so that's what our two presentations are in line with today. So first, I would like to introduce Dr. Peacher to come on screen with us. Hi, Dr. Peacher. How are you? Thanks for being with us today.
Thank you for having me.
So if you just want to briefly introduce yourself, I like to give the opportunity to our presenters to do that. And then we'll let you have the floor for a little bit. And again, we'll take the questions and answers at the conclusion.
Okay. Hi, everybody. My name is Annacecilia Peacher. I am a urogynecologist working out of Monmouth Medical Center in Long Branch. So I'm going to actually talk a little bit about what a urogynecologist actually does. So we're going to talk today about understanding your pelvic health. A lot of people don't really understand what a urogynecologist does and that it's an actual subspecialty of OB-GYN. So this is after training about GYN and obstetrics. It's extra training where we learn about various things, including overactive bladder, stress urinary incontinence, pelvic organ prolapse, recurrent urinary tract infections, and microscopic hematuria. This isn't all-inclusive. This is kind of a highlight of common symptoms that patients come with. So better understanding what overactive bladder is. It's a name given to kind of a collection of bladder symptoms. One symptom is urgency, which is a sudden and intense need to pass urine. This usual urge can't be put off. It can happen when your bladder is not full and sometimes makes you leak before you get to the restroom. This is called urge incontinence. There's also frequency of urination, which is going to the restroom usually more than 7 times a day. So usually I ask patients if they're going to the restroom, how often you're going to the restroom. And usually if you have significant frequency, you're going to the restroom about every hour. Nocturia is actually waking up more than once at night to go to the restroom. That's kind of an amount that's more than usual, is more than once at night. And overactive bladder affects women and men of actually all ages. It does become more symptomatic when you're older. So here's just a cartoon that shows the difference between a normal person that is having urine increase in the bladder and the bladder remains relaxed. And this is kind of what happens with urge incontinence. Your bladder starts contracting even when the volume of urine isn't significant. So what causes overactive bladder? Overactive bladder is caused by the muscle squeezing to empty out urine at inappropriate times. And usually this happens without warning and when you don't want it to. Sometimes a cause of overactive bladder could be infection. It can also be caused by conditions that affect the nervous system. When you affect the nerves throughout the body, you can also affect the nerves of the bladder itself. If you've had previous operations for stress incontinence, you might also have more issues with overactive bladder, and we'll discuss stress incontinence in a moment. And there's also different types of liquids that you can drink that can make these symptoms worse. Usually in women, the exact cause of overactive bladder isn't found. And despite that, there's many treatments that we can use to help manage the symptoms. So treatments that are available, first we look at lifestyle modifications, which is we ask what you're drinking throughout the day, and if you're drinking a lot of liquids that have caffeine. There's also something that's called bladder training. So some patients train themselves to go to the bathroom every 30 minutes or every hour, even if their bladder's not really full. So we kind of slowly stretch the amount of time in between voids to help your bladder better regulate when your bladder's actually full. There's also medications that we can use that help relax the muscle of the bladder. Botox is actually a treatment that we can use for the bladder. It's used to kind of stun the muscle of the bladder, and it is used with a camera. Cystoscopy is looking inside the bladder with a camera, and we inject the Botox directly into the muscle itself. This is nice because it doesn't have some side effects that medication can have. Also, you don't have to take a medication every day, and it lasts for about 6 to 9 months, which is nice. There's also peripheral tibial nerve stimulation. This is a treatment that's performed in the office. There is actually an acupuncture-like needle that's placed in the tibial nerve, which is in the leg. It's connected to a low electrical stimulation, and this goes back, the stimulation goes back to the nerves of the bladder, and again, helps relax the bladder. These treatments are once a week. They last for 30 minutes, and the treatment plan is 12 weeks. So it's more of a commitment, but patients that have issues with medication or they don't want to do Botox, that's a good option. There's also something called sacral nerve stimulation. This is kind of one of the last resorts. This is, again, an electrical stimulation, but this is aimed directly at the sacral nerve. And the stimulation is placed actually in the body via a surgical procedure. And then there's a remote that's used on the outside of the body that helps regulate the stimulation. And you change the stimulation with your physician, and you can help relax the nerves to the bladder that way. So now there's stress urinary incontinence, which is a different type of incontinence. This is involuntary leakage of urine that happens more with activities like coughing, sneezing, laughing, exercising. This type of incontinence usually affects about 10 to 20% of women, and some women don't realize that there's some simple effective treatments that are possible for this. Stress urinary incontinence really affects the quality of life of women. It may limit social and personal relationships as well as limiting physical activity. Sometimes you feel like, well, you know, I want to go running, I want to go for a walk, but whenever I do that, I leak, and that's annoying, so I'm going to stop doing those things. Causes of stress incontinence. Pregnancy and vaginal birth are a common cause of stress incontinence. There's also obesity, chronic cough, chronic heavy lifting, and constipation can lead to anything that really increases the abdominal pressure of the person can aggravate stress incontinence. There's also some people that have genetically inherited factors that increases or predisposes them to have stress incontinence. So treatment options for stress incontinence. There's general lifestyle changes like monitoring fluid intake. Some patients think that they're supposed to drink a lot of water to flush out their system, and they really drink near a gallon a day. And usually we say to just drink when you're thirsty. Don't try to.
Okay, I think we're having some technical difficulties. I see that, I think we lost Dr. Preacher. Joe is still on. I think we just lost Dr. Preacher. So let's see if Dr. Preacher comes back on. So just bear with us a minute, okay? Thank you so much.
Sorry, we got
That's okay. This is what we deal with technology, not an issue. Okay, go ahead. Back to you.
Okay, so share screen. Let's see. Okay. So getting back to treatment options, there is monitoring fluid intake. Decreasing body weight helps to decrease stress on the different organs, including the bladder. Avoiding smoking, which helps decrease irritation to the bladder directly. And then there's also pelvic floor exercises, which are also known as Kegel exercises, that helps with strengthening the muscles that you can contract and squeeze prior to having any leakage with coughing, sneezing, laughing. Also helps you kind of use those muscles to help with urge issues. So what are the treatment options besides those for stress incontinence? One procedure is pretty common. It's called a mid-urethral sling, and there's a depiction of it over here, kind of where it's placed surgically, giving support to the urethra. When you have leakage, there used to be ligaments right here that help support the urethra and close the urethra, causing decreased leakage with coughing, sneezing, laughing. So when that's gone, we put this in. It's about 1 centimeter wide, and it's a small piece of mesh that's placed under the urethra, and it exits the abdominal wall, and it's used to help support. There's a small incision that's in the vagina, and then there's 2 small incisions that exit the abdominal wall. It runs behind the pubic bone, and it's used, like I said, for incontinence. So 80 to 90% of women undergoing sling procedures are actually cured from their stress incontinence following surgery. It's important to know that this operation is not designed to cure the other type of incontinence, which is urge incontinence. Although up to 50% of women notice some improvement in their overactive bladder symptoms, this isn't the treatment specifically for urge incontinence. This is for the coughing, sneezing, laughing type of incontinence. Okay, and a small percentage of patients that have this procedure for their stress incontinence, which is the coughing, sneezing, laughing type, actually have worsening of their urge incontinence. So now talking about prolapse. So prolapse is a bulging or herniation of one or more pelvic organs into the vagina. Pelvic organs consist of the uterus, vagina, bowel, and bladder. Pelvic organ prolapse occurs when the muscles, ligaments, and fascia that holds these organs in the pelvis become weakened and then lose the correct position. So what are common symptoms of this? There's a heavy dragging feeling in the vagina or lower back. Sometimes there's a feeling of a lump in the vagina or outside of the vagina. Some patients have some urinary symptoms such as slow urinary stream, a feeling of incomplete bladder emptying, any kind of urinary frequency or urge, desire to pass urine. Some patients actually get the stress incontinence also. Sometimes patients can have bowel symptoms, difficulty emptying your bowel, or needing to press on the vaginal wall to help empty your bowels. There can also be discomfort during intercourse. So what causes prolapse? The main cause is damage to nerves, ligaments, and muscles which support the pelvic organs. And these can result from childbirth, pregnancy, which are considered major factors. Prolapse actually affects 1 in 3 women who have had 1 or more children. Prolapse can also occur during or shortly after a pregnancy, or could take years to develop. It is important to emphasize that only 1 in 9 women ever need surgery for prolapse in their lifetime. Aging and menopause further weaken the pelvic floor because of the lack of estrogen in your body. Without estrogen, all of the tissues that help support organs and everything in the pelvis kind of get a little bit weaker. There are some conditions that cause excessive pressure on the pelvic floor, like obesity, chronic cough, chronic constipation, and heavy lifting and straining. Some women could have inherited risk of prolapse, such as Marfan's syndrome or Ehlers-Danlos syndrome. So where does prolapse occur? Prolapse can arise in the front wall of the vagina, which is considered anterior compartment, the back wall of the vagina, which is the posterior compartment, or the uterus, which is the top of the vagina. Usually women have prolapse in more than one compartment at the same time. So this is a depiction of anterior compartment prolapse. This is the most common type of prolapse. It involves the bladder and the urethra bulging into the vagina. So you could hear this is the bladder coming into the vaginal canal right here. Sometimes it's referred to as a cystocele. There's also posterior compartment prolapse. This is the lower part of the bowel, the rectum, which bulges into the back wall of the vagina. This is sometimes referred to as rectocele or enterocele. And then there's apical compartment prolapse. This is uterine prolapse. This occurs when the uterus drops or herniates into the vagina. This is the second most common form of prolapse after the anterior compartment prolapse. Some patients can actually get prolapse after a hysterectomy. And this is where the top of the vagina, where the uterus was, comes down into the vaginal canal. So how is prolapse treated? One option is to do nothing. Prolapse is rarely life-threatening, and many women will choose not to have any treatment if they have no symptoms or discomfort. If you are diagnosed with prolapse, try to avoid any kind of heavy lifting, chronic straining with constipation and excessive weight gain. Those things will worsen your prolapse symptoms. You can also perform pelvic floor exercises like I discussed previously, which helps with their stress incontinence. These are, like I said, also called Kegel exercises. Exercising your weakened pelvic floor muscles can help improve or prevent the worsening of early stages of prolapse. So just like with any exercise program, pelvic floor exercises require time, motivation, and proper technique. Other treatments for prolapse, pessary can be used. This is a vaginal device. It comes in various shapes and sizes. Pessaries can help by providing mechanical support to the prolapsed organs, thus relieving symptoms. Pessaries are most suitable if you wish to delay or avoid surgery. They require fitting and can require some trial and error before the most suitable size is found. It is possible to have sexual relations with some of the pessaries that are placed in the vagina. So what surgical options are there? Some women with symptomatic prolapse have a surgical repair in mind, and this is most appropriate considering your age, previous surgical history, severity of prolapse, and your overall general health. The purpose of any kind of pelvic reconstructive surgery is to restore the pelvic organs to their natural position while retaining sexual function. These procedures can be performed vaginally, abdominally through an abdominal incision, laparoscopically with little incisions on the abdomen, or robotically, which is the same management as laparoscopic. So when trying to understand what surgical approach could be right for you as the patient, there are, like I discussed, a variety of different approaches, and there's no single best approach. The vaginal approach usually involves making an incision directly in the vagina, separating the prolapsed organs involved from the vaginal wall, and then using stitches to strengthen and repair the vagina. Permanent stitches can also be used at the top of the vagina or the cervix, and they can be attached to strong ligaments in the pelvis to help support the uterus or vaginal vault. There's also the laparoscopic approach. Usually the primary surgery performed is called a sacrocolpopexy. This is resupporting the vaginal vault using mesh, which is attached to the front and the back of the vagina. This is abdominally performed, and these are attached to a ligament on the sacrum right here. This is usually performed at the time of a hysterectomy. So approximately 75% of women having a vaginal surgery and 90 to 95% of women having an abdominal approach. Abdominal approach meaning any of the surgery performed from the abdominal side, whether it be open, laparoscopic, or robotic. Those patients have a 90 to 95% of long-term cure from prolapse. Recurrent prolapse can occur if the continued factors happen that have caused the prolapse in the first place, such as constipation and weak tissues. So now going on to other issues that patients have coming to a urogynecologist. One other issue is recurrent urinary tract infections. Usually a urinary tract infection is considered recurrent if you have 3 infections in 6 months or 4 infections in 1 year. These should be positive urine culture infections, meaning you went to the doctor, you had a urine culture, and it was indeed positive for infection. Having repetitive infections can increase your risk of kidney infections. It may need to be evaluated to make sure there's no identifiable cause that could be causing this, such as a stone, bladder mass, or polyp. And it's possible that a patient needs to be placed on low-dose antibiotics for 6 months to aid in prevention of future infections. We also treat microscopic hematuria. This is a low amount of blood that's found during routine urine analysis. This blood is found in the urine when you don't have an infection. The kidneys and the ureters need to be evaluated, and this is usually performed with renal ultrasound. And then the bladder needs to be evaluated, which is performed during cystoscopy. That's looking inside the bladder with a little camera. We need to make sure that there's no causes of the blood that can be fixed, such as stones, masses, polyps, or possible early signs of cancer in the kidney, the ureter, which is the tube from the kidney to the bladder, or the bladder itself. So in conclusion, there's many different things that a urogynecologist can treat. Overall, the subspecialty aims at improving a woman's quality of life by both conservative management of certain issues or surgical management. And that's it. Thank you.
Okay, Dr. Peacher, we have a couple of questions that have come in.
Okay.
What if I think I have both urge and stress incontinence? Is there a way?
So if you think you have both urge and stress, then you usually we ask questions to figure out which one is causing you the most leakage, and then we address that type of incontinence first, and then we kind of wait about 4 to 6 weeks and see how you're doing with that primary type of incontinence, and then follow up with the secondary type. But because the different types of incontinence are treated differently, we usually go after the most bothersome first and then follow up with the second kind.
Okay. Are there any long-term effects if any of these symptoms are not addressed?
So with the stress and the urge incontinence, those usually just worsen with time. They're not going to cause any type of cancer or anything that is really detrimental. You might have an increased risk of urinary tract infections that can cause kidney infections, that can cause kind of sepsis that goes through your body, which is pretty rare. Really, with urge and stress incontinence, if they're not addressed, they will just worsen, really hindering quality of life. Okay. With prolapse, usually it worsens and it takes a pretty long period of time to worsen. Usually it's just a quality of life issue. However, it can get to a point causing urinary retention, meaning you can't empty your bladder completely. And that again causes issues with recurrent infections, issues with your kidneys and kidney function. It can also, because it's outside of the body, that tissue is not made for that. It's supposed to be inside the body. Sometimes you can get a wearing of the tissue, which can cause skin breakdown and ulcers.
Okay.
So those are usually the consequences of not treating them.
Okay. What is your opinion, doctor, on using yoni? I don't know if I'm pronouncing it properly. Yogi eggs for supporting pelvic floor health. And perhaps you can explain what that is for those of us who don't know.
So I think that's referring to like a weight that you can use. They come in different weights and sizes, and you can place them in the vagina and do the Kegel exercises with them. The idea is to graduate or to decrease the.
We may have lost a connection again. Andrea, can you just confirm if that's Dr. Peacher's connection and not mine?
Yes, Mary Beth. Unfortunately, it does seem to be Dr. Peacher's connection.
Okay. All right. Thank you. I'm not sure if she's going to have the chance to come back on. You know what? Why don't we do our public service announcement right now, and we'll give her a chance to maybe come back and answer that question. I'm going to come back on. Okay. All right.
Okay. That's a good idea.
Okay. All right.
So this is what happens when you deal with technology.
That's right. But Dr. Peacher's back. Okay. All right. Well, let you answer that question, Dr. Peacher.
So I don't promote one type of exercise over another. I really think just the simplest way of doing the exercises is the best. Also, if a patient needs additional instruction, we can always refer to a pelvic floor physical therapist that really does one-on-one training with exercising the certain areas of the pelvic floor and kind of monitoring improvement.
Okay. That was actually going to be one of my questions. There are physical therapists that specialize in that type of rehab.
There are. Mhm.
Wonderful. Okay. Well, I thank you very much for your time today. And again,
Yeah.
if anyone has any follow-up questions, you can certainly put them in the comments. Again, we'll forward them on to Dr. Peacher, and we do send out an email thanking everyone to attend. For attending, so I can follow up in that. So Dr. Peacher, thank you so much for your time today.
Thank you. Thanks for having me.
Thank you. Andrea, should we do our public service announcement then
Yeah.
at the end?
We might as well do it right now.
Okay.
Since here we are.
Okay.
Public service announcement time.
Okay, so our public service announcement for SCAN will be that our next Lunch and Learn is on October 15th. And our presenters are Horizon Blue Cross Blue Shield of New Jersey. And we also have Monmouth Medical Center returning for another presentation about your cholesterol and knowing your numbers. And let's see, what else do we have? Andrea has diabetes, right?
Of course I do. So we're doing another virtual diabetes self-management workshop. This one is going to be in the evening, and we actually have a few slots left. So it's going to start Thursday, October 8th. It'll run through November 12th. It'll be from 6 to 8 p.m. This is a free 6-week workshop. It's good for people who have diabetes, need a little help in managing it. If you're pre-diabetic, it's excellent as well. Or if you're someone in your home has diabetes and you're the caretaker, you're the cook, you want more info. So if you would like to register, just call SCAN at 732-542-1326, and we'll get you out the registration info that you need.
Perfect.
So that's what I want to say about diabetes. But one more plug I'll make for SCAN. SCAN FYI, which you can watch every Wednesday at 9 o'clock on SCAN's Facebook page. It's a 15 or 20-minute short segment. Mary Beth and I are the co-hosts. We have all kinds of interesting guests every week at 9 o'clock, SCAN's Facebook page. So it's facebook.com/ScanNJ. So check us out.
Wonderful. Thank you, Andrea. So next, I would like to invite Joe Morales to join us on screen.
Okay, I will.
Hello, Joseph. How are you?
Good, Mary Beth. How are you guys doing?
Good, thank you. So, Joseph, I will give you the opportunity to introduce yourself. And again, you're coming from CareOne, and I will hand it over to you.
Yeah, so my name is Joseph Morales. I'm a licensed physical therapist here in the state of New Jersey. I'm currently working at CareOne as the director of rehab for our skilled nursing facility here at King James in Atlantic Highlands. And I also oversee our assisted living at Jackson. I'm a board certified specialist in geriatric physical therapy. I know you mentioned a while ago that there are other physical therapists working in other settings, like they're mostly specialized in other areas. So my specialty is geriatric. We're going to be talking about fall prevention today, as that's one of the common areas that are concerning with our geriatric population right now. So I would like to share my screen. Let's see. So I just want to confirm that you guys are seeing the screen.
Yes, right now I see fall statistics.
Correct. All right. Oh. So let me backtrack. All right. So this is the falling in love is fun, but falling down isn't. So I bet everyone agrees on that. So fall statistics. Why should we be concerned about falling, and statistics about falls, factors involved in falling, ways to reduce the risk of falling, and how therapy can be of benefit to help reduce those risks. So just a brief overview, national statistics, 37% of persons 65 and over fall at least one time a year. 87% of fractures in the elderly are result from a fall, and persons who are 75-year-old and up who fall more than 45 times are more likely to be admitted to a long-term care facility within a year or so. Falls are the leading cause of accidental death in persons aged 70 and up, and falls are the most common cause of non-fatal injuries in hospitalization. Prevalence and incidence. Accidents related to falls are the sixth leading cause of death in elderly aged 75 and over. Hip fractures increase the death rate 8 times in the 75 plus age population, and mortality is also 15% greater during the year following a hip fracture. So it's really important to discuss about fall prevention. Common areas where falls occur: 41 to 60% of falls per year occur in either hospital or a nursing home setting, usually when toileting at night, when the patient is like half awake, they're still disoriented, or they're medicated, and also when trying to get out of bed. 28 to 45% of falls per year occur at a patient's own home or a person's own home or in the community. Some of them are rushing to the bathroom if they have those incontinence, what like Dr. Peacher discussed. And some are tripping, tripping with if they have tripping hazards like cords, wires, newspapers, or their pets. Some fun fact: women fall more than men. The rationale behind that is that women live longer. Depending on the age bracket, the ratio of women to men can be as high as 11:1, and they have a greater sway in their gait because of their body habitus, the wider pelvis, so they sway a little bit more when they walk. Some causes of falls include people under 75 years. How and why do people fall? People under 75 years of age usually trip, and people over the age of 75, usually when they turn, they fall. It could be related to vestibular or balance issues, or they have limited rotation, like limitation of motion, if they have other comorbidities such as arthritis and other factors like pain, and the tendency is to fall sideways instead of backwards. Why is fall prevention a major concern for older adults? According to the APTA president of the geriatric section, Jennifer Bottomley, she made this statement: when Jack and Jill fell down the hill, we assumed they just dusted themselves off and went on their way. But with the elderly, it takes a devastating toll on their life and on their limbs. Some of the consequences include fractures, head injuries, internal injuries, abrasions, sprains, dislocations, and psychological fear. And once somebody fell one time, even they might be afraid of getting up anymore. Like if you have an elderly mom, aunt, or grandparents that fell, you would notice a decline in their mobility because of fear. It also impacts their activities of daily living, their day-to-day performance. People become more guarded and they slow down. And studies show that if we walk 1.5 miles per hour, we don't usually fall. But if we walk slower, because there's a tendency of a lot more start and stop, we can't keep up with our center of gravity moving forward. So you have higher chances of falling. Consequences include loss of independence, of course, increased cost of care, poorer prognosis, stress on family, staff, in a facility, increased need for home services and other resources, and a greater chance of being admitted in a skilled nursing or a long-term care facility. Some intrinsic factors involved in falls: the loss of ability to control balance. So if we don't practice balance tasks enough, like standing on straight, one leg, eyes closed, shifting leg, and there's a reduction in their lower extremity strength. So most geriatric or adult population, the decrease in activity, they usually just sit, sedentary lifestyle. So those are some of the factors that cause fall. There are some other disease too that can be complicated because of a fall, like cardiovascular, You know, once you start falling, you decrease your activity. Now you have poor endurance. You start having claudication, like neuropathies, and then the orthostatic hypotension is big too. Like if your body's not used to the upright position, when you stand up, your blood pressure tends to drop. So that's like a vicious cycle now, because you're not getting enough exercise, you're not getting up. Now your body is accommodated to a lower blood pressure. So once you stand up, it drops even more. And also, like people who had strokes, you know, they have some hemiplegia, half of their body is paralyzed. They have perceptual motor changes and changes in their cognition. Parkinson's disease, they have difficulty initiating movement. Their tone, they tend to be rigid or stiff at times. So those are causes of falls. Diabetes, again, diabetes, they can cause neuropathy, they can cause cardiovascular and visual changes. And also Alzheimer's. Alzheimer's is that, you know, poor interpretation of cues, like their safety awareness is decreased, their overall tone is decreased as well. If a patient is having some acute infection like UTI, which is common, so fall might be the first sign for our elderly. Multi-pharmacy and alcohol use, like if a patient is going to different doctors and not really discussing with their primary what medication are they on, they might be like side effects of different drugs. And then they can get liver and kidney not able to metabolize and excrete the medication. And then when they compounded that with alcohol use or even light drinking, that could linger in their system and cause them to fall as well. Pain relievers such as aspirin and ibuprofen as well. Medications affecting balance, diuretics. See, diuretics is commonly used to treat heart failure, liver cirrhosis, and hypertension. If you're on a diuretic, you have a tendency to, you know, increase urination, so people will rush to the bathroom. The hypotension, like what I discussed, the orthostatic hypotension, when there's a sudden change in position, you can have a lower blood pressure, and then you can be lightheaded, and that could cause fall. Sedation, lethargy, and dehydration as well. Other medications, the antihistamines, the psychotropics. So make sure that if your doctor, whether you're primary, whether a specialist, prescribe a new medication, really discuss with them what are the side effects. Discuss what medications are you on. Are they going to be having some interaction with that? And also you need to be aware of the side effects. If you're experiencing it, try to call your doctor right away. Try to call your specialist right away. So that way we won't wait till the last minute, because a lot of times the doctor will prescribe a medication and then they will say, see you in 30 days or see you in 3 months. Then as a good patient, we try to follow strictly what the doctor prescribes. So we keep on taking the medication, because that's what they recommended. But in fact, if we're having some side effects, we should just pick up the phone, call them right away, and then, or even discuss with your pharmacist. So pharmacists also know a lot about medication. Malnutrition and dehydration. If we don't drink enough water, we can get dizzy. Our body stiffens up. So ideally, you want to drink eight glasses of water, 2 liters a day. You know, and if we're not getting enough nutrition, we can have a low blood sugar that could cause us to fall as well. Some also calcium deficiency. Poor judgment and confusion in disorientation. This is commonly for patients or people with Alzheimer's. Again, they have poor safety awareness. They might just get up without proper shoe wear or proper footwear. That could cause them to fall. So some of the intrinsic factors, 15% of falls are called accidental. So it could be due to the environment. It could be to lack of practice. Some of the environmental factors are, you know, if a bathroom or a hallway in your house are not well lit. You know, you get up in the middle of the night, you want to go to the bathroom, and then that could be a hazard if it's not well lit. Some of the things we can do to prevent falls. Walking. Walking is very good because not only it helps us keep our strength, keep us from moving, keep our joint integrity, it's also good for our cardiovascular conditioning. Yeah. So when we walk, we try to stand upright, take full steps. We wear supportive shoes or footwear. We use caution, especially on stairs and uneven ground. Use a walking aid if either your primary doctor or physical therapist has prescribed one. And we try to maintain like a car, our canes and walkers. Some of the rubber tips can be easily worn down, especially if we walk on pavement. So we try to replace them and then check on them every so often. It's also good to consult with physical therapists. Prevention, I think, I see a lot of times patients and people don't realize that physical therapists are experts in movement science. So we studied about kinesiology, physiology, mechanics of gait. So by the time we see a patient coming into our clinic or coming into our facility, we're already analyzing how you guys walk. It's funny how sometimes it becomes a routine for our physical therapist's eyes that by the time a patient is walking, we're already, or a lay person is walking on the street, we're already analyzing their gait. So we can assess your balance, your strength, and prescribe you with a good program that will, maximize your independence and reduce the risk of falling. Getting up and sitting down from a chair, ideally you want to use the one with the arm. The sofas that are soft, that are either too low, it's hard to get up from, so it could pose a risk for falls. And also installing some grab bars and other aids in the bathroom is advisable. A lot of physical therapists work in home health setting. I used to work for a home health agency. I go to people's house. I help out their patient to set up their house, their environment to be optimal for their function and their safety. So a few things, consult with a PT for strength and balance, and consult with either a PT or an OT about safety equipments. So balance, we can make changes in our home, like what I said. We can do like a routine stooping or reaching overhead. You don't want to do it. If you're doing it routinely, make sure that you have a good balance. If you feel like you're going to fall or you're going to, when you reach overhead, try to be cautious, ask for assistance. Use a walking aid. Use caution, extra caution in stairs and curb negotiation. And then keep your hands free to use the rail and wear supportive shoes. Medication, carry an up-to-date list of your medication with the doses, especially if you're going to a specialist, so that way they know what your primary MD, primary doctor prescribed. Try to buy medication at one pharmacy so you have a relationship with the pharmacist there. They're a good resource of the side effects of the common drug interaction. Try not to take over-the-counter medication without asking your healthcare provider. Report any dizziness, weakness, confusion, or unsteadiness to your healthcare provider or a physical therapist. Ask if any treatments other than medications will help your problem, like what Dr. Peacher mentioned. I know it's not fall related, but she said that, it's not all about medication, not all about surgery. There's a special group of physical therapists that can help you with some incontinence. So those are other treatment options. Same thing, taking multiple medication can increase your risk of falling. Ask the healthcare provider at every visit if you still need those medication, or it can be reduced or even stopped. Drops in blood pressure or dizziness. I highly suggest that if you're on a blood pressure medication, you try to take your blood pressure every day, same time, same place, and same position. Never walk when you're dizzy. Drink 8 ounces of glasses every day, unless you have been advised to limit your fluids. So, because water is good, but again, you don't want to overfill yourself with fluids, especially if you're on fluid restriction. Yeah, you can find out if your BP drops with your change in position. You know, you can have your healthcare provider check your blood pressure in laying down and standing, report any change in your status like dizziness, and again, you know, carry a list of medication with you all the time. Vision or hearing problems, the numbness of feet can cause fall as well. Have a yearly vision and hearing checkup. Keep eyeglasses clean and never walk when wearing reading glasses, because reading glasses tends to magnify everything around us. Use extra caution on uneven surfaces, and make daily routines simple, you know, so that way you don't have to go through environmental hazards in your living area. Like a lot of people, if they have a 2-level house, they'll try to stay in 1 level until they're all done, and then go upstairs to the bedroom if it's time for them to sleep, so they don't have to negotiate the stairs back and forth. Always wear proper shoes, wear socks that are breathable. High heels, especially for women, we don't encourage them more than 1.5 inches. Sole should be at least wide and non-slippery. And you know, the socks and shoes should not leave marks in the skin when removed, because if it does, it means that it's constricting your blood flow, or you're getting some water retention. And you can consult a podiatrist too to manage your regular foot care for any foot pain. Some hazards at home: remove anything that narrows the walking paths, remove all possible tripping hazards like throw rugs, electrical cords, loose flooring, assure adequate lighting, and always get help in changing ceiling light bulbs, smoke detector batteries, and other chores that require climbing. So what to do if, God forbid, you fall? You think ahead and plan what you might do if you fall. So I would suggest most of the elderly that I work with, we recommend the life alert button, or if not, carry their cell phone with them. So that way, if you're unable to get up, you would be able to dial 911. A lot of times with the technology, they use the Amazon Alexa. They can have Alexa call 911. They hook up their phone to the Alexa app, and you'll be able to get assistance. And if you fell, of course, you're going to consult your healthcare provider. If it's serious enough, you're going to go to the emergency room. And if you've noticed change in your balance and you keep on tripping, you know, go to your therapist. A lot of the therapists can evaluate you now. You don't even need a prescription in the state of New Jersey. You can go to your therapist, they will evaluate you, and then they will call your primary doctor and develop a plan of care that's suited for you. So we're wrapping up. We have preventive interventions are the most effective way in preventing falls. Adding exercise in your routine, you know, daily routine, that includes strength, endurance, and flexibility. Consult with a physical therapist. We are the expert in movement science, so we can assist you with that to safely give you a program that you can do every day. I'd just like to share with you some of the things we do here at CareOne King James. We use a lot of technology to get you back on your feet. We partner with ACP. So we use OmniStand in getting you back in shape, practicing your balance safely, avoiding risk for fall. We have the OmniCycle that will help you exercise both feet and arm, or we can do either feet or arm, and we can monitor your vital signs. We can see how you respond to exercise. It's a controlled environment. And we also incorporate virtual reality now, the technology. So we have a virtual reality, and then this lady is with the OmniStand. So we're incorporating that as well. So for any other questions, you can let me know, or this is the website to help you with the fall prevention. Thank you.
Joe, let's see. We have a couple things in our chat. Okay. And I was chuckling because my mom's physical therapist would always analyze her as you were walking through the parking lot.
Yeah, exactly. Yep.
She would say, "How do you know?" And he's like, "I was watching you."
Yeah.
Vision impairment, and how is that impairing someone's balance, and what therapy can be done to help someone who is experiencing, I guess, balance issues because of a vision impairment?
So usually, like what I said, a physical therapist, we coordinate with the primary care doctor and the other specialists. We evaluate a patient, we assess them. We just don't assess their strength. We assess everything. If they're having any visual deficits and visual impairments, we will refer them to a ophthalmologist or optometrist. Some of the most common visual impairments that we use are like if they're having some peripheral vision issues. So we teach them compensatory strategies. We teach them to scan first before they start walking, because most of the falls happens that if their peripheral vision is impaired, they can't see the barriers on their side. So they either trip, they either knock the doorknobs and all that. So we develop a strategy with them. We advise people to consult with a therapist that can evaluate their home environment to make it easier for them to function in their house safely.
Okay. Somebody has a relative that's experiencing what they're referring to as knock knee. Are there any long-term effects if that is not addressed?
Yeah, well, knock knee, when you say knock knee, most commonly knock knee is caused by an arthritic knee. So I would highly suggest them to consult with an orthopedic specialist or a rehab medicine doctor, which we call a physiatrist. Because most of the time there's something more than strength decrease in strength that's causing the knock knee. There's some like structural thing going on there. But you can go to a physical therapist. They can advise you with an appropriate assistive device that you can use to prevent from falling, God forbid, if they're having issues with falling already because of the knock knee, or either that, or if they're having any pain. Long-term effects, if not addressed for the knock knee. I mean, some people are born with it, like especially knock knee is common in women because of the wider pelvis. We call it the Q angle. So most often than not, women have a tendency to have more of a knock knee than men. But yeah, it's a case-to-case basis, really. It's on how the severity of the knock knee is. Most often than not, it's due to an arthritic knee. I hate to say it.
Okay. And then revisiting center of gravity.
Yes.
And why someone would not want to walk slow because of that.
Okay, correct. Yeah.
Clarify that a little bit.
Yeah, as well, I know a lot of times we tell, before I became a therapist, a lot of times we tell our grandparents, like, hey, grandma, try to walk slower so you don't fall. But when I became a physical therapist, I learned that not walking slower is not really beneficial equivalent to not falling. So when I advise my patients, try to walk at your normal pace. Yeah, you're not going to run, you're not going to brisk walk, but walk at your normal pace. Because when you walk slower, most often than not, like what I said, the center of gravity is off your base of support, and there's a lot of more start and stop that could cause a person to fall even more. And also, like if you're a community ambulator, there's a study that you need to walk 0.6 miles per hour to safely ambulate in the community, like crossing the street. So if we always tell our patients walk slower, it's safer, then we're limiting them to be a community ambulator. Because the pedestrian, the walkway, the traffic light is, you need to be able to walk X amount of speed to safely cross the pedestrian. So I advise walk at your normal pace. If you feel like walking at your normal pace you're falling, then you have some balance impairments that you really need to see a physical therapist. Yeah, and then consult with them what could be causing that.
Right, that's great. Well, I thank you that you
Oh, thank you. Thank you for your time.
are going to come back on screen. Some wonderful information was shared with you and with Dr. Peacher today. So we thank you both for your time. At the conclusion, we're going to put a slide up that has everyone's contact information. So thank you very much for joining us today,
All
Joseph.
right. No problem. I appreciate your time. Thank you. And stay safe, everyone.
Thank you, Joseph. Andrea, I'm not sure if you're going to come back on screen with me. Here's
Sure, here I am.
So thank you again, everyone, for joining us today. I'm going to put the slide up, but before I do that, we did miss one public service announcement. AARP is offering a 3-part webinar series, which we just put out, I guess it was last week. And those begin on October 8th. Fraud Watch, October 22nd is Financial Basics, and October 29th is everyone's favorite, 6 Pillars of Brain Health. So that's up on our website and you can sign up for that right there. So thank you all for joining us today. Andrea, is there anything else you'd like to add?
Well, not too late to sign up for classes. It's an ongoing thing, so feel free to sign up. You know, we're still virtual, and a few of the classes might be full, but most of them you can still sign up and participate. We'd love to have you.
Yes, thank you for the
Okay.
plug for my programming, Andrea.
Of course.
Okay, well, thank you again, everyone. And the next Lunch and Learn is on October 15th. Again, feel free to go to SCAN's website, www.scannj.org, and register right there on the flyer. So have a wonderful afternoon, and we will see you all soon. And I'm going to put up contact info.
Thank
Okay.
you, everyone.